Thank you, Tobias, and everyone for the kind invitation. I've been assigned the difficult task to open up with all the technical possibilities from an engineering and a chemical perspective. So I'm going to struggle now in the next 10 minutes to provide you lots of information that hopefully comes back in the more applied talks that follow. So what we're trying to address is a clinical need and a need to discriminate disease from healthy tissue. And basically in the surgical field, it's not always obvious which targets or which light bulbs in this sense need to be removed and which ones should stay in. And that can be rather confusing or tiresome even. So the thing that we're trying to achieve with imaging is to just illuminate the odd one out, right? So really light up the tissues that are relevant as targets and that need treatment. And today we focus on nodal metastases, and then you have different routes of targeting these. So it can be either lymph nodes, the sentinel node targeting, which is basically lymphatic drainage, or targeting of PSMA expression. I will come back to that in the end of the talk. What I would like to start with is the technical aspects. And one thing that we find is absolutely critical is the imaging beforehand. So independent if you do sentinel node imaging or PSMA imaging during surgery, the roadmap that nuclear medicine provides is critical for the success of the execution of the surgery. So basically, the surgeon needs to know beforehand, one, if the targets are there, and two, where the targets are located. So to emphasize this, here you see an overview of a study that we did where we had a sentinel node tracer that was radioactive and fluorescent. And we blinded the surgeons for the preoperative imaging. And then we saw that with fluorescent imaging, we could only detect the nodes in half the patients. So it's really the intraoperative imaging is highly relevant and highly valuable, but the preoperative roadmap is equally critical. Because we're going to talk about intraoperative imaging all the time, I wanted to have this out of the way. So we need the preoperative imaging. The risk if you don't use that is that you underestimate what you're looking at, right? So if you look at an image, you usually already have an opinion, and especially with technologies like fluorescence, that can be really tricky and you can get an iceberg-like situation with all the disasters that may follow. So Henk asked me to put in some technical details on optical imaging, on fluorescence imaging. So especially for Henk, I put them in. I won't go through the whole slide, but I think it's important for everyone to realize is that not only the camera settings and properties are critical for the success of fluorescent imaging, but also the dyes that you use, the agents that you use. There are lots of features that can influence the signal, but that can also mess up the signal. So in that sense, for fluorescence, really caution is needed. The rest of the talk, I will focus more on the use of radioactivity. And there we have the concept that the robotic systems as they are now very much mimic the human setup, right? We have a vision in the endoscope, stereoscopic vision. It can do fluorescence imaging that's standardly integrated. And what we now want to do is sort of convert the instrument to sensing devices like your fingertips, but then allowing them to sense molecular features like radioactive tracers. So then we come to the engineering, right? Because when we wanted to do this, there were no such detectors. So we had to design the detectors. So we do this in our workshop. And the concept that we have here is that we try to adapt the detectors. You see in your left screen, that's a traditional laparoscopic detector. Try to adapt it to the steerable robotic instruments so you get optimal degrees of freedom. The solution we came up with was a drop-in gamma probe, which has been in the clinic since 2019 and has been successfully used in sentinel node and PSMA applications. And I don't think you will hear the beeping sound now. So that's actually good because there's a really annoying beep in the background. But you can use this radio guidance in combination with fluorescence imaging, as you see here. And the whole probe can be operated by the robotic surgeon sitting in the far right of the OR. What we found is that this probe, the degrees of freedom it provides, so the fact that it can really articulate with a surgical instrument, really improves the detection sensitivity in radio-guided surgery compared to traditional laparoscopic gamma probes. So with that, it suddenly opened the market for robotic procedures. And something that we explored together with Tobias Maurer, also present here, and others, is the use of the drop-in gamma probe for PSMA-guided surgery. So I think there will be more on this topic later, so I won't go into that any further. What I would like to show is that we can even advance the design beyond what we have now. Is the drop-in probe is something you need to pick up and put down. So there's a bit of a delay logistically. A click-on detector is the next step where you can still manipulate the tissue with your grasper and do the imaging. So that's in the preclinical phase, but there's progress to be made here. Ultimately, what we're moving towards is sort of a surgical workflow where we can combine the imaging beforehand with intraoperative gamma tracing, fluorescence imaging if you can, and hopefully ending up with a happy Hank, as you can see here, assuming that a happy surgeon also means a good surgery and a happy patient in that sense. So it's not only engineering, right? So engineering is part of it, but it's also tracer development. So we also need to do some chemistry because the chemistry defines which targets actually light up. If we then look at prostate cancer surgery, we have a number of features here on the slide. The key ones I want to discuss now are the nodal involvement and the primary tumor. So the nodal involvement you can target with PSMA or with sentinel node imaging. The primary tumor is only PSMA. One critical feature that needs to be kept in the back of everyone's mind when you use these type of tracers is the clearance route. So the prostate lies at an intersection between the bladder and the kidney. So it really anything in urine goes through the prostate. So if you have tracers that are renally clear, that can cause a background signal. So if we then look at the two applications, so on the left sentinel node, on the right PSMA. Sentinel node is a local injection. PSMA is an intravenous injection. The targeting of these two types of tracers is very different. The sentinel node targets via lymphatic drainage. It's not tumor specific, but it lights up tumors that are likely to contain metastases. So it can detect very small metastases, at least it's not related to the size of the metastases. The PSMA targets intravenously. It is tumor specific, but it needs larger metastases for it to effectively target. So there's a limit in size to the PSMA application. The most critical aspects herein is that really limits or really influence the signal intensity. So as you see here at the bottom of the slide, in a typical sentinel node procedure, we have about 1,000 counts with a gamma probe. In a typical PSMA procedure, we have about 130 counts with the gamma probe. So going from lymphatic imaging to receptor targeted imaging means you almost get a 10-fold loss in signal intensity. This combined with background signals, etc., really makes the receptor targeted approaches way more difficult compared to the sentinel node. So there's always a misunderstanding that people think, hey, it works with sentinel node, I can do now receptor targeted. Yes, you can, but it's not that trivial. So what we did for the sentinel node is we developed a so-called hybrid tracer where we combine the value of a radioactive tracer that accumulates in lymph nodes with the value of fluorescence guidance. So we can have the whole radio guidance as I showed you with the preoperative imaging, but we can complement it with fluorescence imaging, as you can see here. And you know, based on these results, we also see that there's an interest for such technologies in PSMA targeted surgery. So we recently did a Delphi consensus, and this is one of the questions that we addressed. And then when we asked the urologist what type of guidance modalities they would like, and they basically say either gamma probe or fluorescence or a combination of the two. The other technologies, either they did not have enough knowledge about, so they were quite neutral, or they did not have an interest in. So based on this, we argued that it made sense to also make a hybrid PSMA tracer. So this is some of the work that we did. Again, I won't go through the chemistry, but the main thing that we try to address next to affinity are the pharmacokinetics. So we try to design a tracer that would not end up in the urine and would not contaminate the surgical field. So that's lots of work. At the moment, we're translating this tracer to the clinic, and we used preclinical studies for that. So you see Paolo Dalloglio in the background doing the robotic surgery at Orsi. And this is a trajectory that we're now going through to also get the hybrid approach in the PSMA guided surgery. So basically extend the radio guided as is, and as will be presented later on with fluorescence. Yeah, from a chemical perspective, one thing that we need to keep in mind is the false negatives and the false positives. So do we need sensitivity or do we need specificity? If we want to raise the signal, can we raise the dosing? And maybe it sounds very trivial for most, but it really, in fact, it's not. So if Tobias is doing PSMA targeted surgery, he's using microdosing. If someone else is trying to mimic the same approach with fluorescence guidance, they're using like almost 100-fold or even 1,000-fold higher dose of agent. So that really changes the rules of the game. So from a chemical perspective, I would really urge everyone to think about the dosing that they use, and well, if that can yield false positives or false negatives. So just to round up, as you see, there are lots of aspects to this. I try to cover mostly the technical ones, but it's really a team effort. So we need multiple disciplines to work together. And as a final slide, some acknowledgements. And with that, back to you, Tobias.
Well, thank you, Fijs. I mean, this was really a great overview. I mean, you've done tremendous work, and your group on tracer development, on development of detectors.